am Dr. Preethi, Associate Professor, Department of Pathology, Senior Consultant in Pathologist in NABL Aggregated Laboratory. I have more than 30 publications, international and national, and 15 patents and 5 grant and 8 years of teaching experience in both UG and postgraduate. Now we are just moving into the today's topic, disease of white blood cells, lymph nodes and spleen. So today our objectives will be hematopoiesis, disorders of white blood cells, lymphadenitis, neoplastic proliferation of white blood cells, neoplasm of mature TK cells, NK cells, plasma cell neoplasm, Hodgkin lymphoma, myeloid leukemia, myelodysplastic syndrome, myeloproliferative disorder, splenomegaly. Disorders of white blood cells and broad classification, that is, it is broadly divided into quantitative disorder, qualitative disorder, neoplastic disorders and mixed secondary disorders. In quantitative disorder, leukocytosis, that is increase in the WBC count more than 11,000 10 power 9 per liter in adults, and leukopenia, total WBC count less than 4,000. And in congenital qualitative disorders, you will be having congenital and acquired. In congenital, it occurs due to genetic or inherited defects in the leukocyte function or morphology. Acquired will be functional or morphological abnormalities. In neoplastic disorders, leukemia, lymphoma and plasma cell dyskaryosis. Plasma cell dyskaryosis is also otherwise called as plasma cell neoplasm. And mixed secondary disorders, it occurs due to reactive changes, drugs and bone marrow failure. We are just going into some important categories like leukocytosis, increase in the WBC count, leukopenia, decrease in the WBC count, neutrophilia, increase in the neutrophils, neutropenia, decrease in the neutrophils, lymphocytosis, increase in the lymphocytes, lymphocytopenia, decrease in the lymphocytes, monocytosis, increase in the monocyte, eosinophilia, increase in the eosinophils, eosinopenia, eosinophils, decrease in the eosinophils, basophilia, increase in the basophils. So now we are just moving into the qualitative disorders, leukemia, lymphoma and plasma cell dyskaryosis. In leukemia, there will be proliferation of hematopoietic cells in the bone marrow and in the blood. And in lymphoma, neoplastic proliferation of lymphocytes in lymphoid tissue will be seen. In plasma cell dyskaryosis, neoplastic proliferation of the plasma cells will be there. So it's a broad classification. Now we are just going into lymphadenitis. There are two types, non-specific and specific. In acute lymphadenitis, the cause will be mostly the bacterial. Here you will be having nodes are enlarged, tender and soft. In microscopically, you will be having dilated sinusoids with neutrophilic infiltration, necrosis and abscess formation may occur. And there are different types of lymphadenitis, follicular hyperplasia and paracortical hyperplasia, which will be seen in chronic lymphadenitis. The difference between the acute lymphadenitis and chronic lymphadenitis is the chronic lymphadenitis occurs by 4 weeks, but after 3 weeks, on treatment, if the lymphadenitis is continuing, it is called as chronic lymphadenitis. So in specific, some of the specific conditions are there like tuberculous lymphadenitis and cat scratch disease, fungal lymphadenitis. So we are just moving into the difference between acute non-specific lymphadenitis and chronic non-specific lymphadenitis. In acute non-specific lymphadenitis, it occurs due to bacterial infections. Nodes are enlarged, tender, soft. Microscopically, you will be having dilated sinusoids with neutrophilic infiltration, necrosis and abscess formation will be seen, and common site will be the cervical, axillary and the inguinal lymph nodes. In chronic non-specific lymphadenitis, there are 3 types. One will be the follicular hyperplasia, another will be the paracortical hyperplasia, third will be the sinus histiocytes. In follicular hyperplasia, you will be having prominent follicles and active B cell proliferation, which will be seen in chronic infections like rheumatoid arthritis, toxoplasmosis. In paracortical hyperplasia, expansion of T cell zone, that is immunoblast proliferation will be there, which is predominantly seen in viral infections. In sinus histiocytes, dilated sinus with macrophage proliferation will be there. It will be seen in chronic inflammation. The WHO classification of lymphoid neoplasm, there are 5 broad categories. One will be the precursor B cell neoplasm, peripheral B cell neoplasm, precursor T cell neoplasm, peripheral T cell and NK cell neoplasm, Hodgkin lymphoma. Now we are just going to see about the some points regarding each classification. So the lymphoid neoplasm is broadly diagnosed by two things. One will be the pathogenesis of identifying the pathogenesis, another will be the laboratory investigations. In pathogenesis, the most of the neoplasms occurs due to chromosomal translocation and oncogene activation, which causes dysregulation of the MYC gene, which causes viral oncogenesis. Second will be the activation of tyrosine kinase, which causes viral oncogenesis and immune dysregulation, chronic antigenic stimulation. Laboratory investigation for the lymphoid and leukemia are: first will be the more clinching will be the peripheral blood smear, bone marrow aspiration and biopsy. Third will be the lymph node biopsy, and another special test like flow cytometry, that is more specifically means immunoflow cytometry, and another will be the cytogenetic and the molecular studies. So we are just going to move into the lymphoid neoplasms. First will be the type more common neoplasm, that is acute lymphoblastic leukemia. Second will be the chronic lymphoblastic leukemia. Third will be the diffuse large B cell lymphoma, follicular lymphoma and Hodgkin lymphoma, Burkitt's lymphoma, mantle cell lymphoma, marginal zone lymphoma, hairy cell leukemia. So now we are just going to see about the acute lymphoblastic leukemia, that is arrest. It occurs due to mutation and translocation of T1221 and ETV6 RUNX1. It has a good prognosis on treatment. So it is commonly seen in children of 2 to 10 years. Male are more commonly affected. In the peripheral smear itself, you can see n number of lymphoblasts, which will be looking like a large nucleus, scanned cytoplasm and no granules. Bone marrow shows more than 25% of lymphoblast, and it will be a hypercellular smear because the smear will be totally covered with lymphoblast. Second will be, you can identify the ALL by cytogenetic molecular study, where you will be eliciting the translocation of 1221, translocation of 922, hyperdiploidy. And immunophenotypic study reveals positive for CD10, CD19, CD22 and TDT, and CD2, 3 and 7 will be highly positive for ALL. In chronic lymphocytic leukemia, there will be BCL2 overexpression, and common in elderly. Males are more affected, and here you will be having increased mature lymphocytes and the smudge cells. And in bone marrow, you will be having more than 40% of lymphoblast and reduced myeloid series, that is neutrophil, lymphoblast, myelocyte, metabomyelocytes, everything will be reduced less than 20 to 30%. In cytogenetic study, we will be having the deletion of 13q, deletion of 11q and deletion of 17p. And in immunophenotyping, you will be positive for CD19, 20, CD5 and CD23. And for next we are just moving into follicular lymphoma. Here the germinal centers, it's a germinal center, that is B cell tumor. Follicular lymphoma is a B cell tumor which will be having the overexpression of germinal center B cell tumor, translocation of 14, 18 and BCL2 overexpression will be there, and middle age group of people will be affected more. Here the males and females are equally affected in follicular lymphoma. Here you will be having a buttocks like cell, that is cleaved nuclei, that is called and sometimes the lymphocytes will be reactive in nature, and few atypical lymphocytes will also be seen in the peripheral smear. In bone marrow, you will be having diffuse sheets of large cells with high mitosis, and cytogenetic study you will be having BCL6 rearrangement with the translocation of 14, 18, and immunophenotyping it will be positive for CD19, CD20, CD10 and BCL6 will be highly positive. In diffuse large B-cell lymphoma, BCL6 rearrangements will be seen and it occurs mostly in the age of above 60 years. Here there will be large number of atypical lymphoid cells in the peripheral smear. Bone marrow, you will be seeing large number of atypical cells with high mitotic figures. And here in cytogenetic study, you will be having BCL6 rearrangement with translocation of 14-18. In immunophenotyping flow method, you will be assessing CD19, 20, CD79A positive. Burkitt's lymphoma will be having translocation of 8 and 14 and overexpression of MYC gene and proliferation. It is sometimes associated with EBV virus. It is more common in the children with the age of 4 to 10 years and here the males are more affected. Medium in peripheral smear, you will be having starry sky pattern due to macrophages and marrow in bone marrow, you will be having a marrow with vacuolated blast. In cytogenetic molecular study, you will be revealing the translocation of 8-14, translocation of 2-8 and translocation of 8-22 will be seen. And immunophenotyping, you will be having CD19, CD20, CD10, BCL6 will be highly positive. Here the K67 index will also be 100% positive. Next we will be moving into Hodgkin lymphoma where there will be activation of NF-kB pathway and it is associated with EBV virus. And it is a bimodal age group, both adults and children are affected. Here the males are more affected than the female. Rarely abnormal cells are seen and Reed-Sternberg cells are seen in the bone marrow and cytogenetics non-specific, sometimes 9q24 translocation and amplification of the genes will be encountered in Hodgkin lymphoma. Here CD59, CD30, PAX5 will be highly positive in immunophenotypic study. Mantle cell lymphoma, translocation of 11, 14 and cyclin D1 overexpression, cell cycle dysregulation will be encountered. Here elderly males are affected, few atypical lymphocytes and marrow shows diffuse and nodular infiltration, translocation of 11, 14 and Q13, Q32 will be noted and immunophenotyping CD19, 20, CD5 will be highly positive. Marginal zone lymphoma, chronic antigenic stimulation will be seen. Adults 40 to 70 years will be affected. Females are more affected in the marginal zone lymphoma. Usually peripheral smear it will be normal. Sometimes lymphocytosis will be encountered in the CBC and in the peripheral smear. The values of the lymphocytes will be high. In bone marrow, involvement will be less noted in marginal zone because for marginal zone lymphoma, the biopsy will be the confirmatory to say and another will be the cytogenetic molecular study and the immunophenotyping methods confirms the marginal zone lymphoma. In cytogenetic molecular study, you can elicit T translocation of 11, 18 and translocation of 1 and 14, immunophenotyping CD19, 20, CD5 will be positive. Hairy cell leukemia, BRAF and V600 E mutation will be there which blocks the MAPK pathway activation. Morely middle age group affected. In peripheral smear, hairy cells with cytoplasmic projections are seen in the blood smear. In bone marrow, fibrotic marrow with dry trap is seen. And cytogenetic molecular study reveals BRAF V600E. Immunophenotyping flow cytometry shows CD19, 20, 11C, 25 and CD103 and annexin A1 will be highly positive for hairy cell leukemia. Second will be the chronic lymphocytic leukemia where you can see the smudge cells. These are the smudge cells and these are the atypical cells, nucleated RBC and another small lymphocytic lymphoma, you can see the effacement of the lymphocytes with other like macrophages, epithelioid cells will be seen. And third will be the acute lymphoblastic leukemia, which is more common in the children. You can see more number of lymphocyte proliferation, that is lymphoblast will be more than 25% in the bone marrow and in the peripheral smear. Second, we are just moving into the neoplasms of mature T cells and NK cells. Neoplasms of T cells are further classified into peripheral T cell lymphoma, angioimmunoblastic T cell lymphoma, anaplastic large lymphoma, anaplastic large cell lymphoma, adult T cell leukemia bar lymphoma, extranodal NK bar T cell lymphoma nasal type, enteropathy associated T cell lymphoma, hepatosplenic T cell lymphoma, and Sézary syndrome, large granular lymphocytic leukemia. In peripheral T cell lymphoma, it occurs more commonly in the middle age group. Males are affected. It occurs due to the TCR signaling, and in peripheral smear you will be having atypical lymphocytes and which will be in the peripheral smear, which may show reactive and the sometime atypical lymphocytes can also be seen. In bone marrow, marrow involvement will be more than 30%, and in cytogenetic and molecular findings you will be having no specific cytogenetic hallmark, and immunophenotyping CD3, CD2 and CD5 will be positive. Angioimmunoblastic lymphoma is another one of the rarest lymphoma, which will be occurring less than 10 to 15% of the age group. It occurs more commonly in the adult more than, and female is the preponderance, male is the preponderance age group. It occurs due to the origin from the follicular helper T cells and mutation in the IDH2. In peripheral blood, you will be having atypical lymphocytes, and in bone marrow, you will be having polymorphous infiltration with arborizing vessels, and cytogenetic TER2 ROHA mutations will be seen, and immunophenotypic CD2, CD3, CD4 will be highly positive. Anaplastic large cell lymphoma, you will have translocation of 215 and NPM ALK fusion, which constitutes the ALK tyrosine kinase activation. Children are more affected, males are the more affected one in sex, and large anaplastic cells, that is horseshoe shaped cells, will be seen in the peripheral smear. In bone marrow, marrow involvement will be variable, and cytogenetic study you will be having translocation of 2,5 and P23 and Q35, and immunophenotyping CD30, ALK and EMA will be highly positive. Large cell anaplastic large cell lymphoma, it's like similar to anaplastic large cell lymphoma, but still here the ALK mutation will be negative. It occurs due to the mutation in the DUSP22 and TP63, and it occurs in older age group above 60 years. It has similar of atypical cells in the blood. Marrow involvement will be variable, and DUSP22 rearrangements and TP63 mutations in the suppressor gene will be noted in cytogenetic and molecular study. In immunophenotyping, it will be positive for CD2+, CD3+, CD5 and CD25+. In extranodal NK but T cell lymphoma nasal type, it is associated predominantly with EBV, that is Epstein-Barr virus. It occurs in the middle age group. Males are more affected. In peripheral blood, you will be having cytopenia, and marrow infiltration will be seen with atypical lymphocytes. HTLV1 proviral DNA integration will be seen in cytogenetic molecular studies. And in immunophenotyping, CD2 and cytoplasmic CD3E and CD56 will be highly positive. Enteropathy associated cell lymphoma, it arises with celiac diseases. It occurs due to the clonal expansion of the T cells. It occurs more commonly in the elderly age group. Male is the preponderance. Rare circulating atypical lymphocytes will be seen in the peripheral smear, and bone marrow involvement will be uncommon. Here the here it can be identified by the immunophenotyping method only by CD3, CD7, CD103 high positive. Hepatosplenic T cell lymphoma, neoplasms of gamma and gamma T cell. It is more commonly seen in the immunosuppression people like HIV, and it occurs in the young age group. Males are the predominant people who are getting affected. Cytopenia and medium sized atypical lymphocytes will be seen in the peripheral blood. Sinusoidal infiltration is seen in the liver, spleen and bone marrow, and here isochrome 7q and trisomy 8 mutations will be seen here, and CD3, CD56, CD4 and CD3 and CD56 will be positive, and CD4 and CD8 will be negative. Sézary syndrome, which is otherwise called as mycosis fungoides, neoplastic CD4 plus T cell home disease, and it occurs more commonly in the older age group. Male is the preponderance, and it is like in Sézary, cells can be seen in the blood and bone marrow. There will be diffuse infiltration of the T cells, and no consistent cytogenic hallmarks can be elicited in the cytogenetic study, but in immunophenotyping it will be positive for CD3, CD4, CLA and CD7. Large granular lymphocytic leukemia, which is occurs due to the chronic proliferation of cytotoxic T cell STAT3 mutation. It occurs in both age group, like it can occur in the younger age group as well as in the middle age group. Both male and female are equally affected. Large granular lymphocytes with eosinophilic granules are seen in the peripheral smear. Bone marrow, interstitial and sinusoidal infiltration with the malignant lymphocyte cells can be seen. In cytogenetics study, you can see the STAT3, STAT5b mutation, and immunophenotyping CD3, CD8, CD54 and CD16 will be highly positive. Moving into the plasma cell neoplasms and related disorder, first will be the monoclonal gammopathy of undetermined significance. Second will be the asymptomatic myeloma, otherwise called as smoldering myeloma, multiple myeloma, otherwise called as plasma cell myeloma. Third will be the plasmacytoma, that is solitary or extramedullary myeloma, plasma cell leukemia, then lymphoplasmacytic lymphoma, heavy chain disease, amyloidosis. The monoclonal gammopathy of undetermined significance is the more common plasma cell neoplasm, which is encountered more than 50% among all other plasma cell neoplasm. It occurs due to the clonal expansion of plasma cells producing monoclonal IgG M protein without end organ damage. It occurs more commonly in the above 50 years of age group. Male is affected more, and normal or few plasma cells will be noted in the peripheral smear. Bone marrow shows plasma cells and the normal architecture will be there, but it will be effaced with malignant plasma cells. And cytogenetic study, you will be having trisomy 3 and translocation of 11 and 14 will be elicited, and immunophenotyping CD38, CD138 will be highly positive. In asymptomatic myeloma, it's an intermediate stage between the monoclonal gammopathy of undetermined significance and multiple myeloma. It occurs in the age group of 50 to 70 years. Males are more affected. Here you will be seeing the occasional Rowlex formation, and 10 to 60% of the plasma cells you can see in the bone marrow. Cytogenetic study, you can see the translocation of 11 and 14 and deletion of 13q, and CD38, CD138 and CD56 will be highly positive. In multiple myeloma, after monoclonal gammopathy of undetermined significance, the other most common tumor will be the multiple myeloma, otherwise called as plasma cell myeloma. Here you will be having malignant clonal proliferation of the plasma cells. producing M protein, and it occurs in the elderly age group of 60 to 70 years. Male are affected more than the females. Here you will be having the plasma cells in the circulation, but the RBC picture will be normocytic normochromic, and here more than 10% of the plasma cells and sheets of atypical cells, Russell and Dutcher bodies can be seen in the bone marrow. It occurs due to the translocation of 11 and 14. Immunophenotyping, it will be positive for CD38, CD138 and CD56. Plasmacytoma, solitary or extramedullary plasma neoplasm, localized plasma cell tumor, and it occurs in the age group of middle aged to elderly. Male are more affected. In peripheral smear, it will be looking like a normal, no abnormality can be elicited in the peripheral smear, but in the bone marrow there will be mass of plasma cells in the bone and soft tissue, and here you will be having a translocation of 14q and 32. Immunophenotyping will be positive for CD138 and 38. Plasma cell, second we are just moving into the plasma cell leukemia. Here you will be having the circulating plasma cells more than 20%, and it is a very aggressive tumor, and it occurs in elderly age group, that is above 40 years, and male and female are equal in distributed. The numerous circulating plasma cells, anemia, thrombocytopenia will be elicited in the peripheral smear. In bone marrow, there will be diffuse infiltration of the plasma cells, and deletion of 13q, deletion of 17p, and translocation of 11 and 14 will be elicited. In immunophenotypic study, CD38, CD138 will be highly positive. In lymphoplasmacytic lymphoma, clonal B cells with plasmacytoid differentiation, IgM monoclonal gammopathy will be seen, and it will be occurring in age group of above 60 years. Male is more commonly affected. Here in the peripheral blood you can see the Rowlex formation, small lymphocyte, plasmacytoid cells, and bone marrow you can see the infiltration of small lymphocytes and plasma cells, and cytogenetics you can see the mutation of L2, 65p mutation, and deletion of 16q. CD19, CD20, CD22 and CD79A will be highly positive. Heavy chain disease, neoplastic plasma cell secretes heavy chains like alpha, gamma, which causes plasma cell dyskaryosis. It occurs more commonly in the middle age group, may show atypical lymphoplasmacytic cells, diffuse infiltration of the lymphoplasmacytoid cells in the bone marrow, and gene deletion in heavy chain locus. Immunophenotyping CD19, 20 and CD38 will be highly positive. Amyloidosis, AL type. Here the plasma cell dyskaryosis is a monoclonal light chain, amyloid deposits in the organ. The most commonly affected organ will be the kidney in amyloidosis and liver. The males are commonly affected, and elderly age group above 60 years are affected, and peripheral smear you will be having Rowlex formation in the RBC or plasma cells will be seen. In bone marrow few plasma cells will be seen, and the special stain Congo red elicits the amyloid deposition in the bone marrow. And similarly in cytogenetic study you will be having a translocation of trisomy 3 and translocation of 11 and 14 as you see in multiple myeloma and monoclonal gammopathy of undetermined significance. The immunotyping will be CD38 and CD138 will be highly positive. So this is the picture showing X-ray showing a multiple myeloma of the skull with all opacities, that is punched out bone lesions which showing the opacities. In the second picture it is a bone marrow picture showing a vacuolation in the cytoplasm, and in nucleus you will be seeing prominent nucleoli and prominent nuclei in this picture. So this is the M protein, this is the normal electrophoresis showing the normal band formation, but in multiple myeloma patients you will be having the band, M band, that is M protein band will be highly positive when monoclonal gammopathy of undetermined significance. And lymphoplasmacytic lymphoma, here you can see the plasmacytoid cells in the bone marrow biopsy, and here you can see the varied number of lymphocytes with atypical lymphocytes everything and small lymphocytes in the picture. Thus we conclude with today's topic. In part 2 we will be dealing with the Hodgkin lymphoma, myeloid leukemia, myelodysplastic disorder, myeloproliferative disorder and myelodysplastic disorder and splenomegaly.